Good evening, all. My name is Dr. Giovanna Thomas, and I am presently at the University of Miami Department of Otolaryngology, Head and Neck Surgery. I am the co-director of the Fellowship Training Program in Oncologic and Microvascular Reflux Surgery. I direct the Minimally Invasive Robotic Surgery Program in the department, and I lead the Diversity and Inclusion team in the Department of Otolaryngology, which is my second passion. Welcome to the webinar entitled The Pandemic Papers, Trends Over Robotic Surgery Research and Practice Innovation, Years to 2020 and 2021. Firstly, I want to thank Dr. Holsinger for inviting us to moderate this webinar. So thank you. Secondly, I want to acknowledge my co-moderator. He's actually a superstar. His name is Dr. Kartik Rajasekharan. Many of you know of him. He's at the University of Pennsylvania, Department of Otolaryngology. He's the co-director also of the Head and Neck Oncologic Fellowship Training Program. He is the director of facial trauma, and he's the director of the quality improvement for head and neck surgery and microvascular reconstructive surgery. In addition, Dr. Rajasekharan has done a most amazing job putting this webinar together, and I thank him very, very, very much for doing that. Finally, I want to thank our distinguished panelists for their time and commitment to do this webinar. They will be introduced further in the webinar, but without further ado, I will pass this on to Kartik.
Thank you very much, Dr. Thomas. Is all lies. You have done a tremendous job on this. I wanted to also take this opportunity to thank Intuitive Surgical for sponsoring this webinar. We really appreciate your support. Perhaps you can lend us another SP at our institution for free. All right, so we are extremely fortunate to have 5 very, very qualified panelists. Thank you all for coming. First up, we have Dr. Cohen. She grew up in Miami, Florida, graduated from the University of Florida. She completed both her medical school and residency training at the University of Miami and is currently pursuing a 1-year fellowship at the University of Pennsylvania. I can tell firsthand she is a phenomenal fellow. I don't think she really even needed a fellowship, but with a special interest in TORS and oropharynx reconstruction, she is eager to apply her clinical skills, her research and mentorship to her new future academic job. I think that's an ad that she is interested in pursuing a job perhaps, but realistically, she's got multiple offers. Then Dr. Hutchinson, she's a professor in the Department of Head and Neck Surgery at the University of Texas MD Anderson Cancer Center. She is the chief for speech pathology and audiology. She serves as the director of research in the section of speech pathology and audiology. She is also the director of the Voice Center and the audiology fellowship director. Next up, we have Dr. Nicoli. She is an assistant professor at the University of Miami School of Medicine. She is also the associate program director of the residency program. She has several very passionate traits, but one of the things that I hear a lot about from all the residents and fellows is she's very passionate about resident fellow education. And we are very fortunate to have her. Dr. Orozco, he is an assistant professor at the University of California, San Diego, where not only is it very sunny, we're all jealous. He specializes in head and neck oncologic surgery. He is co-leading a translational research lab that is devoted to advancing the field of robotic surgery. His work in the UC San Diego Contextual Robotics Institute focuses on melding engineering and medicine. Some very cool stuff. And finally, we have Dr. Van Abel, who, unlike all of us, actually did surgery today, I think. I speak for myself when I say I didn't do anything. She's an assistant professor at the Mayo Clinic. Her main research focus is oropharyngeal squamous cell carcinoma with a specific emphasis on HPV-driven disease. She conducts prospective randomized interventional de-escalation trials and maintains an extensive registry that offers insight into patient oncologic outcomes. She also studies biomarkers, including circulating tumor DNA and as well as the oral microbiome signature. So the main purpose of this webinar is to highlight some of the manuscripts that were published during the years 2020 and 2021, the COVID pandemic years. And the pandemic kind of prevented us from actually meeting in person and discussing some of these papers. So the purpose of this webinar is to really highlight some of those missed papers, discuss them, and then get excited for the meeting that's coming up next week in Dallas. So each panelist will highlight the key points from 2 selected manuscripts. This will be an interactive session, so there will be a live poll, which will pop up on the screen and you guys will respond. We'll then share the responses. During each presentation, if you have any questions, please type it in the chat box. Dr. Thomas and I will compile them and ask the panelists on your behalf. We'll try to do that in between sessions and then probably save a lot of them for the end of all the panelists. So we will try a trial question. Will you be attending the AHNS meeting in Dallas? Yes or no? Oh, that's some fast responses. All right. Well, looks like we have 62 responses and 104 participants. My math is not great, but oh no, 62 of 97. So, all right, I hope you guys know it shows up on my screen, but if you participated, thank you. If you're trying to figure it out, you have 10 more questions to figure it out. So, all right, so you can share those results. Oh, stop sharing. Okay, so with that, I am going to hand it over to Dr. Cohen, who's going to take it away.
Thank you. Give me 1 second. I'm going to share my slides. All right, so first I wanted to take the opportunity to thank Dr. Rajasekaran and Dr. Thomas for the introduction and for inviting me to join this TORS webinar series as we gear up for the upcoming AHNS meeting next week. So I want to start by polling the audience. And so I have 2 questions that I wanted everyone to take a look at. The first question, I'm just going to read it out loud. It says, for HPV positive oral pharyngeal cancer, are there de-escalation treatment protocols available at your institution? And the second question is, does your institution treat primary site and neck as separate entities when considering treatment? And so I'll give you a couple of seconds to answer. All right, I think we have about 68 people are still responding, so I'm just giving it a little bit of time, but we have about 68 responses, so I'm gonna end the poll. And here we have the results. So it looks like actually a pretty interesting split. So for the first question, it looks like about a little more than a third have more than half of the patients enrolling. About 20% have the available de-escalation protocols, but most patients don't enroll, and about 40% do not have de-escalation protocols. And then regarding the question with the primary site and NEC as separate entities, actually very interesting. So this is about 50-50. So just to briefly review, de-escalation trials can be put into two separate categories. Those that, I'm not sure why this is popping up again. Those that de-escalate after TORS and neck dissection, and those that involve de-escalation after non-surgical treatment. In addition to radiation dose reduction, de-escalation may involve replacing, reducing, or omitting chemotherapy. Data from the AVOID trial was published in March 2020 by the group at the University of Pennsylvania. The primary aim of the trial was to decrease radiation toxicity by avoiding targeted radiation to the primary site after TORS. This was a single-arm phase 2 prospective clinical trial that enrolled 60 patients treated with TORS and neck dissection from 2014 to 2017. Patients with AJCC 7th edition, T1 and T2 node positive HPV-associated oropharyngeal cancer were included. All had favorable features at the primary site. In other words, negative surgical margins at least 2 millimeters and no perineural invasion or lymphovascular invasion. Patients received postoperative radiation to the involved neck at 60 to 66 gray and the uninvolved neck at 54 gray. Concurrent chemotherapy was added for 13 patients with extranodal extension, and patients were followed for a median time of 2.4 years. Radiation fields for the neck typically include low-dose delivery to the primary site, secondary to the nature of radiation protocols. The image on the left is a depiction of a radiation treatment plan in a patient from the study with a T1 N2A base of tongue tumor as outlined in pink. As shown in the box plot in the middle, mean measured radiation dose to the primary site in the trial was 36.9 gray, which is a 40% reduction from the standard targeted volume. The average primary site dose did not differ based on the location of primary site, whether the tonsil, tongue base, or glossotonsillar sulcus. Only one patient recurred at the primary site, one patient recurred in the neck, and 2 patients developed distant metastases. Measured 2-year local recurrence-free survival was 98%, and overall survival was 100%. Feeding tube dependence rates were 0% both during treatment and long-term, and only 2 patients had temporary late soft tissue necrosis at the primary site during treatment, which resolved within 2 months. This study concluded that de-intensified postoperative radiation that avoids the resected primary site and targets the at-risk neck after TORS may be safe and is worthy of further study. Some limitations include small sample size with relatively short follow-up, limited application to a later T stage, and the fact that the surgeries were performed by high volume experienced TORS surgeons, so they may not be as widely applicable. Okay, so now I'm going to move on to my second article. So I want to start again by polling the audience with a few more questions. So I have 2 questions here. The first one is, what percentage of your TORS population is over 70? And the second question is, do you have an age cutoff that you use in determining whether a patient is a TORS candidate? All right, so we have about 58 responses. I think we can end the poll and look at the results. So for what percentage of your TORS population is over 70? It looks like very few selected, of course, more than 50% as expected. And the rest is kind of distributed somewhat evenly. There's about 26% from 0 to 10%, 10 to 30%, 10 to 30% was about 50%, and then 30 to 50%. And then for the age cutoff, the overwhelming majority said that there's no age cutoff. and about low percentage picked age cutoffs of 70, 75, and 80%.
Hey, Aaron, can I ask a quick question about that?
Yes, of course.
Or just I wanted to chime in, like I was in the no cutoff group, but I also feel that while, like, for instance, I think my oldest TORS patient is this really cool guy over at Berkeley. He's like 80, he was 80 when I operated on him, he's 84 now. He has done great, but for 18 months, you know, his spinal accessory, even though I knew I saved that nerve, just would not budge. And it took him, you know, instead of like the 45-year-old, the 55-year-old who's having a radical tonsillectomy, they bounce back in 2 weeks. It took him kind of months. And he lost a lot of weight. So while I don't have an age cutoff, I consider age as a really important part of my decision making. And I'd be curious to hear what you, Aaron, have to say about that, and some of the other panelists.
Yeah, definitely. So I'm going to present a paper that actually talks a little bit about the age factors. And I came across several papers that were kind of using not just age, but also other markers of frailty. So I think that's a really, really interesting point. So this paper that I'm going to present first looks at expanding TORS to the elderly patients. It's a paper out of Thomas Jefferson, published in the summer of 2020. This was a retrospective cohort study to determine if elderly patients have differences in functional and survival outcomes compared to non-elderly patients following TORS. So why is this relevant? Well, the incidence of HPV positive cancer has been found to be increasing in older patients, with a third of patients in the US greater than 65. This group is projected to continue to increase through 2045. In addition, many elderly patients don't qualify for approved chemotherapy regimens, making surgical approaches more appealing if they do, in fact, qualify for surgery. And in the era of de-escalation, they may be able to avoid any adjuvant treatment or even de-intensified treatment, which may be better tolerated in older adults. So in this study, 246 patients undergoing TORS from 2011 to 2016 were included, and 64 were considered elderly. A cut point of 70 years was used based on prior studies of oropharyngeal cancer in the elderly. Functional status was evaluated with diet, enteric feeding status, a functional oral intake scale, tracheostomy tube placement, and unplanned readmission. Significantly higher proportion of elderly patients had base of tongue tumors relative to the non-elderly patients. And although 85% of the entire cohort was P16 positive, elderly patients were less likely to have P16 positive tumors compared to non-elderly. Non-elderly patients were also significantly more likely to receive adjuvant chemoradiation. And looking at functional outcomes, although elderly patients were more likely to be discharged with enteric access, the difference was no longer apparent 3 months after treatment. The authors hypothesized that the need for enteric tube feeds in the immediate postoperative period in the elderly could potentially be related to poorer baseline function, swallowing coordination, and a decreased capacity for swallow therapy. However, overall, the cohort did have very favorable swallowing outcomes, with only 5.6% G-tube dependence at 1 year, and the rates in non-surgical populations can be as high as 31% in the literature. There was no significant difference in any of the other factors, including diet, tracheostomy tube rates, and perhaps the most surprising, in unplanned readmission. And I also want to point out that no patients were readmitted for aspiration pneumonia. So Kaplan-Meier curves for disease-free and overall survival, adjusting for P16 status, are also depicted here. The authors found no significant differences in disease-free survival, as shown on the left, and on overall survival, as shown on the right, between the age groups after adjustment for P16. Limitations of the study included using 70 as a marker for elderly, which in of itself is not synonymous with frailty. Cohorts were not matched in terms of adjuvant therapy, P16 status, and anatomic subsite. Future studies using well-defined markers of frailty and matched controls, as well as incorporating de-escalation in this population, are indicated. That's it. I'm going to stop sharing.
Great, thank you, Dr. Cohen. While Dr. Orozco is gonna, Dr. Hutchinson goes next, we had a couple of very interesting questions by Dr. Hoey. Do any of the panel members consider PNI to be a non-favorable finding in HPV in comparison to LVI? So perineural invasion. If so, could we provide the evidence base for that? Anyone here want to chime in?
I do consider PNI or LVI both as higher risk features. I don't have an article that I can cite off the top of my head. I think that there was a composite score that was published a few years back that used PNI. I don't know that I necessarily look at PNI as a worse prognostic indicator than LVI, but certainly something that could be looked at. It seems to me like if you're in a situation where you unexpectedly can't achieve negative margins, when you go down and talk to the pathologist, they'll say that the lymphovascular spaces are full of tumor. And that's often why, it can be challenging to clear a tumor that it seemed like you would be able to ahead of time. So I think that that's a biologic marker that may not be something you can tell, just by looking or feeling.
Thank you. Yeah, it's interesting. If that is the only indication for radiation, unless it's on a large nerve, we typically do not radiate. There's no great literature on this. I think this is just our experience. Anyone else have any thoughts? All right. Well, next question was from Dr. Scholl. What final margins in millimeters are considered favorable for inclusion in the VOID study? I think that was 4 millimeters, right? Oh, it was 2?
Yeah, it was 2 millimeters.
2 millimeters. All right, I have never seen that. Yes, so Dr. Hoey commented he's never seen a paper that shows PNI as a negative, but multiple papers show negativity for lymphovascular invasion. And that's right. We really don't have good literature on this. Yeah, maybe a good opportunity for a multi-institutional study. All right, so next up we have Dr. Hutchinson.
So are you seeing the correct side of the slides? Yeah, okay, great. So thanks for having me today. We're going to start off with a polling question, pretty basic. In your opinion, most diet restriction in the acute postoperative recovery period after TORS is due to what factor? Pain, physiologic impairment in swallowing, or both? You guys answer fast. Okay, we've got about 70 responses in. Let's go ahead and share the results. So we have about an even split, about a third of the group saying pain, a few singular responses, probably by my speech pathologist in the audience saying swallow impairment, and then about 2/3 of folks saying probably both swallow impairment and pain. And hopefully the data we'll review today will sort of tip you toward that third answer. I would answer probably both. So I chose two papers, which are actually the popular vote of the panel, that are both digging into the modified barium swallow study data to characterize post-TORS swallow function. And this is specifically in cohorts of patients who have been treated for primary disease, typically T1, T2 volume. And so the first one we're going to look at is out of Emory. First author is Lauren Ottenstein, and Lauren's on the participant list today. So hi, Lauren. And the senior author on this paper is Mihir Patel. So this was a single institution retrospective review. They included 139 patients. All patients were treated with primary TORS for T1, T2 tongue base and tonsil tumors or unknown primary. The majority of the time, those unknown primary patients had the tumor identified. And all patients had ipsilateral neck dissections. And this is a paper that's going to look just through the post-surgical period and not at results after adjuvant therapy, which I think is important. They have pre and post-operative, very comprehensive functional outcomes assessed, and the baseline function of this group is not unexpectedly excellent. So across a variety of validated outcome measures, 100% of patients are on a full oral diet without feeding tube dependence, 95% report unrestricted diet levels, 96% with normal airway protection, which is according to the penetration aspiration scale score of 1 or 2 on a modified barium swallow study. And then if we look at the results of the swallow study more broadly, beyond just aspiration, about 80% of patients fall very squarely into the group of having what we would call a functional swallow. So by the digest grade that we developed here, which focuses on both safety and efficiency of clearance, about 80% with grade 0 or grade 1 results. And according to the MBS IMP that was developed out of MUSC with Bonnie Martin Harris, which focuses on swallow physiology, again, about 80% of patients having normal or functional physiology at baseline. So let's look at the findings in the acute postoperative period. So the modified barium swallow studies, again, here are prior to any adjuvant therapy, and they were on average conducted about 3 weeks postoperatively. And you can see about 40% of the cohort at the 3-week mark has moderate to severe dysphagia according to the digest methodology. This is accounting essentially for penetration and aspiration of the bolus into the airway, as well as residue as a marker of inefficient swallowing. And, you know, historically, we thought that most of the dysphagia severity in TORS was driven by inefficiency, but these data actually highlight that about a third of these patients, about 30% of patients, have grade 2 or higher. So this is moderate or severe safety impairment. And that would represent patients who have multiple episodes of aspiration, not just an isolated single event. You can see about 17% are aspirating more than one consistency, and about 80% of the time, most of the time, it's from residue after the swallow that's being aspirated into the airway. That is the same pattern we expect after radiation, by the way. This is also seen to be matched with very high prevalence of physiologic impairment. So this is the percentage of patients who have moderate to severe impairment in specific elements of swallow physiology, and you can see those rank ordered here. Predominantly in factors associated with bolus clearance, so pharyngeal stripping, which is that sequential pharyngeal constriction, superior to inferior, base of tongue retraction, pharyngeal contraction, but also some of the laryngeal elements of swallowing, including closure of the vestibule and epiglottic inversion. They did multivariate analysis, and these are the independent factors predicting that acute post-surgical dysphagia, not surprisingly age. But also, importantly, some subclinical findings of that baseline modified barium swallow study, specifically slower swallows, which we know are an age-related factor, as well as less efficient swallows. Neither of these features of that baseline modified barium swallow study that can sort of risk stratify those individuals who will struggle more in that post-surgical period, would I argue are things that you'll pick up by watching a patient swallow in clinic. They also identified that the site of disease predicted differences in the physiology of swallowing, but not in the severity of dysphagia. And so here we see some of those data just very briefly. To orient you, on the right-hand side are digest grades pre and post stratified by site of disease. And you can see that among those 42% of patients who had moderate to severe dysphagia after TORS, there's sort of numeric trend toward increasing prevalence in tonsil patients relative to unknown primary, green to blue, and in tongue base relative to tonsil, but this was not statistically significant. What was statistically significant was simply the nature of the dysphagia in the tonsil cases, with a higher prevalence of soft palate impairment, as well as pharyngeal constrictor impairment. We see non-significant but higher trending of laryngeal impairment in tongue-based cases. So that's paper 1. We're going to move on to paper 2. And here's our polling question. After recovery of the acute toxicities of treatment, swallowing impairment on video fluoroscopy is more severe in patients who receive primary radiation compared to primary TORS for low to intermediate risk for pharynx cancer. And I guess if I were polling the Astro audience, I'd get a different response profile, but because they would look to the orator data, but I'm polling you guys. And We've got about 60 responses in, and so we can close the poll. And we've got about 3/4 of the audience answering that yes, dysphagia is more severe in patients with primary radiation, and we have about 1/4 of the audience answering no. All right, so let's look at some data. These data come from MD Anderson. These were first authored by Dr. Carly Barbone, who joined our faculty this year, and I also see her on the panel participation list, so hi, Carly. And this is also a single institution cohort study. It's from prospective registry data, where we sampled out 257 consecutive patients treated for low to intermediate risk HPV-associated disease. They were then stratified by their primary treatment strategies. So primary TORS with an ipsilateral neck dissection, about half getting adjuvant therapy, and you can see a fairly even split between radiotherapy and chemoradiation, about 1/4 getting bilateral radiotherapy fields. And then about 2/3 of the sample had primary RT, and 80% of those patients had concurrent chemotherapy, and 80% had bilateral radiotherapy. Baseline function again, so the theme here sticks, is excellent. So mean MDADI scores of this group were 92, which is well within the optimal range. Over 80 is optimal. And about 95% of this patient population had optimal digest grades and swallow physiology. I will say there may be a little bit of difference in the results because these are blind rated in the lab as opposed to clinically rated. So the baseline swallows look a little bit more prevalent in the ideal range in this group relative to the Emory data. Subacute swallowing outcomes on modified barium swallow studies. So this is after the full treatment package, 3 to 6 months after treatment. You can see that a lot of that acute post-TORS dysphagia has improved. So as a reminder, the post-op 3-week data in the TORS group from Emory suggested 42% of patients with moderate to severe dysphagia, and that's down to about 5% of patients here at 3 to 6 months. So the first thing we learn in these data is that that acute post-surgical dysphagia really does recover for the vast majority of these patients, which I think is quite important. We see also, and in speaking to some of the data that were presented earlier, you know, the 30% gastrostomy dependence at a year is simply, I feel like, an unfair sort of comparator in modern times. Here we see moderate to severe dysphagia in a at least TNM matched group at only about 13% in this group, and almost no feeding tubes at this time point. And then a high prevalence of physiologic impairment still shown. What about differences between the RT and the TORS group when we're looking specifically at the video fluoroscopy? Primary results here were that the dysphagia severity, again, according to the digest grading, did not differ between TORS or RT as a primary treatment strategy, but the nature of the physiologic impairments did. And we can see that shown here specifically with these heat maps, where the primary differences were a higher prevalence of laryngeal impairment in the patients treated with primary radiotherapy compared to TORS, and a higher prevalence of pharyngeal contraction impairment in patients treated with primary TORS. And these did on the right-hand side associate with swallowing safety in the patients with impairment in the larynx, and not unexpectedly swallow efficiency in patients with pharyngeal contraction impairment. So those are the data, and for the sake of time, I will stop sharing and move the baton back to our next panelist.
Thank you very much. So the one question from I had quickly was, how many people actually get an MBS post-TORS, at least among the panelists? Do you, is it a routine thing or not?
Routinely.
Interesting. At what time frame?
Anyone who's going to be having adjuvant therapy would be about 4 to 6 weeks afterwards, so right before they start with their adjuvant therapy. And then ideally sometime around that time point for anyone who's having surgery alone. Those are the ones that are a little bit harder to get it scheduled because it's not a really usual time point for them to be coming in at. So, but anyone undergoing adjuvant routinely.
We're the same. We're the same. We really try and get our patients in about 4 to 6 weeks afterwards. ideally.
Yeah, I would say that that's exactly the time frame that we take at Anderson. I like the Emory data actually have a little nested fees component. We like the idea of an early postoperative fees while prior to discharge to really sort of risk stratify those folks who need more intensive help with their swallow in those early weeks. And then we use the modified barium swallow study at that 4 to 6 week mark to be more of their new baseline going into adjuvant therapy, checking for their full recovery and figuring out any additional needs.
Great. And then Dr. Gomez had a question about the Cognetti et al. Paper. Did the authors specify whether they take full thickness of the constrictors for their radical tonsillectomies? Some of us take all the constrictors circumferentially, and some do like a partial thickness. Are you able to comment on that, Kate?
The Cognetti
Did they-
paper was not the one I reviewed. I
Oh.
think that was Aaron's, yeah.
Oh, Aaron, I apologize. Yeah.
On the age-related paper.
Yeah, they didn't comment on the surgery, on like the actual steps of the procedure.
I think that everyone has their own preferences, certainly with regard to the constrictor. My perspective is that taking a partial thickness may have been more of a TLM kind of a practice and holdover. I know that Mike Keeney's trilogical thesis about the thickness taught us a lot about the thickness of the constrictors, that it's only about 2-point-something millimeters thick anyways. I would advocate for taking the full thickness of the constrictor in order to get the fascia as a deep margin. But again, everyone has their own input.
And I can say that that wasn't explicitly specified in either of the swallow study papers that I reviewed, although both, of course, describe kind of a conventional radical tonsillectomy with constrictors being taken.
And then Kate, one last question from Dr. Sadeghi. What percentage of TORS patients had adjuvant radiation therapy in the dysphagia study?
In the Anderson, it was almost exactly 50% had adjuvant radiation, and it was about 20% of the total group that had adjuvant chemo radiation.
Perfect. Well, thank you. All right, next up we have Dr. Nicoli.
All right, let me get my screen going here. Share. Okay, so hopefully these papers will address maybe some of the questions that have been coming up in the discussion. My first poll question: what constitutes an adequate margin in HPV-related oropharyngeal cancer? So knowing on the tumor, negative is negative, 1 millimeter margin, 2 millimeter margin, or a 5 millimeter margin. I think we heard earlier that the AVOID trial used the 2 millimeter margin as their cutoff. And then obviously more traditionally in our surgeries, we talk about a 5 millimeter margin, which isn't always possible in the oropharynx. Give you guys a couple more seconds to answer. All right, so the results are sharing. So it looks like the majority, 53%, say 2 millimeters. And then we're pretty evenly split around the other options. Okay, so hold on. Why is this not letting me advance? There we go. Okay. So the first paper I want to discuss is impact of surgical margins on local control. I just want to highlight actually both of our current head and neck fellows are authors on this paper. So I felt like I had to give them a shout out for this.
This is why everyone loves you.
I'm having a little delay in my screen moving here, but okay. So this is a retrospective review. It's at 3 academic centers: Mass Eye, Hopkins, and UCSF. 99 patients who with HPV-related cancer who were treated with surgery alone. And they divided the cases into close, and their cutoff for this was less than 1 millimeter, versus clear, which was anything greater than or equal to a 1 millimeter margin. And the mean follow-up time was 28.5 months. Okay, so the results showed that a close margin was in 22 patients, so that's 22%. With the tonsillar tumors, the closest margin was most often that deep margin, kind of like we were talking about with the constrictor there. And for tongue-based tumors, the closest margin was most often mucosal. And they found that older patients and higher T and higher N classifications predicted more likely to have a close margin. No other factors predicted that. They looked at smoking, PNI, LVI, a lot of other factors, but those were the only ones that were significant there. And their local control rate was very impressive. So 100% at 1 year, 95.6% at 2 years, and 93.8% at 3 years. And they only had 2 local recurrences in the study, and both of those patients actually on their initial surgery had a greater than 4 millimeter margin. So there was no difference in local control between that less than 1 millimeter group and anything over 1 millimeter. And they also didn't find a difference based on disease subsite, PNI, LVI, or need for re-resection, either intraoperatively or at a second procedure. And this margin status didn't impact disease-free survival or overall survival. And they additionally looked at using the margin cutoff at 2 millimeter and 3 millimeter, and likewise found no difference between those groups. So they stuck with the 1 millimeter cutoff. So just for a better visual, these are those Kaplan-Meier curves, the local control, disease-free survival and overall survival based on that margin cutoff of less than 1 millimeter or greater than or equal to 1 millimeter. And then, so going back to my my poll question, so I circled A, no ink on the tumor. This paper says negative is negative. I included 2 asterisks on that because, you know, it's not a perfect study. It's retrospective. It's single arm. But these are, you know, 3 high volume institutions, and they had really impressive results with it. And so I think it warrants, you know, considering if you have a patient where they're only, you know, negative indication on pathology is a close margin, you know, perhaps it's okay to watch these patients. And I'm curious what, you know, people at other institutions are doing in this scenario.
Yeah, this brings me up to 2 questions that have been brought up. So Dr. Blanco, he wondered, with tissue contraction approximately 20% after being placed in formalin, what is the minimum distance of your margin from the tumor? And do you use specific margin or additional margin on the patient side? And I can say from our cases here, we take it down to the lab, pin it before we don't even put it in formalin. So we ink it, pin it, and so we take the margins that way. Is that what everyone else does, or do you as you want to take separate margins?
We'll take out the tumor, evaluate on the back table, and then I'll take my margins myself with a knife or scissor, and then separate them out and send them. If I feel like I'm close on my resected tumor specimen, I'll take a margin from the patient, and then I'll document which I took from, you know, patient or specimen.
I think it's important that you have good communication with the pathologist to make sure that they're oriented, whether, like Catherine said, she's sending the specimen off to them, or actually walking it over to them, showing them, you know, 1-to-1, and having them cut the specimen in.
And I walk every specimen down too. I just don't pin it. So.
And then Dr. Richmond made a comment that this data, along with other papers, support a no ink on tumor equals negative. So based on that, no need to take the entire pharyngeal constrictor. Swallow function's better if you leave some. Great. All right, Dr. Nicoli, on to the next.
Okay, so my next question. And do we have the poll, Miranda, up for this one? So this is another kind of interpreting your post-operative path. So what nodal factor which of these has the greatest prognostic significance in HPV positive oropharynx cancer? So positive lymph nodes greater than 4, your overall lymph node yield, your lymph node ratio, or doing, bilateral versus ipsilateral neck dissections.
While we're getting these answers, there's two more questions that came up. One for Dr. Van Abel. When you cut a margin, is it a tangential margin or a cross section?
So it's not bread loafed like this. It's a margins that set down, and then they take the shave off the bottom that I orient for them, and then look at that under the slide on their tellurine blue.
Great.
All right, we ready to go on, Karthik, or would you say there's one more question? We're good, okay. So, 57% people said greater than 4 positive lymph nodes. And I think that this is coming from, the AJCC 8 staging criteria where we upstage people based on that cutoff. Oops, hold on. Okay, so this paper published in April of 2020 is coming out of Mount Sinai, lymph node ratio in HPV-associated oropharynx cancer, identification of a prognostic threshold. So this is a retrospective review of a prospectively maintained TORS database, single academic institution, Mount Sinai. He looked at 169 patients with HPV-related cancer treated with TORS and a neck dissection. And they specifically were looking at lymph node yield, which is the total number of lymph nodes in a specimen, and lymph node ratio, which is your number of positive lymph nodes over your total number. So the results on univariate analysis. So lymph node ratio as a continuous variable was a significant predictor of disease-free survival. They found that for every 1% increase in lymph node ratio, the hazard for recurrence of disease or death increased by 2%. And then on multivariable analysis, controlling for age and pathologic T stage and any adjuvant treatment, the continuous lymph node ratio remained significant. And they used this to identify a prognostic threshold as 17%. So just kind of in surgeon terms, if you will, if you had 4 positive lymph nodes out of 20, right, you're above that 17% threshold. Oh boy. Sorry about that. Let's see, from current slide. I have the internet version of PowerPoint on, and that's why I'm slow. So I apologize. Let me get back to where I was.
In the meantime, while they're getting that up, there was a question. What about extracapsular lymph node spread? Does that impact HPV or for HPV-related cancer survival?
So, I mean, what we're seeing with the latest, data specifically out of ECOG 3311 is that less than we thought it did, right? So now we have this cutoff where if it's less than 1 millimeter of ENE, then that's not going to be impacted or not as significant as it was before. So, so I just want to go back to this one slide, which I think is actually probably the most interesting out of this paper, if you don't mind. So this compares the your Kaplan-Meier curves. On the left, you have it based the disease-free survival based on lymph node ratio with the cutoff at 17%. And on the right is you have it by positive number of lymph nodes. So, let 5 or more lymph nodes, right? So that would be your upstage based on our staging system versus less, excuse me. And so, what they're showing is that the lymph node ratio, it's very obvious to me visually looking on the graph, like how more significant that is as a prognostic indicator for disease-free survival. And one of the things I thought that was interesting about this paper is, we're getting really good at treating and curing most of these patients, but there's still that subset that do pretty poorly. So looking for ways to identify those patients beyond what we maybe traditionally think of as high risk in terms of who can we de-escalate and who we can't. But I'm certainly going to start taking a look at this on my own, with my patients with the lymph node ratio. So. So I'm going to stop sharing and turn it back to you, Karthik.
Let me see if I can pull this up.
Oh, and then I did see a question, sorry, just real quick, that you have to interpret it in the setting of lymph node yield. Someone did bring that up in the chat. So they use a lymph node yield greater than 18 lymph nodes as their, so that ratio with the bottom number at least being 18, just to clarify that. Sorry, go ahead, Ryan.
No problem. So good to see you all. Looking forward to seeing you in Dallas, and I'm going to try to figure out how to advance my screen. We're not going to put up a question actually on this. I'm going to end this poll because we're going to, I'm just going to kind of have you think about this first question. So imagine you're sitting in tumor board, you got a patient that you think is a great TORS candidate, and you're reviewing the case at tumor board, and your neuroradiologist points out, well, what about that internal carotid artery that courses way into posterior retropharyngeal direction? Now, what do you do? And so I want you all to think about, is this going to impact your decision-making on offering this patient surgery or altering your surgical approach? And we have a really cool paper that came out in the past year from the Penn group. Here we go. I have it showed up here. Talking about 20 patients that they treated with this retropharyngeal carotid situation. Now, as many of us have initially been taught about TORS, retropharyngeal carotid was either a absolute or a relative contraindication. But as the Penn group has showed us, over time they've started to morph and adjust their indications for surgery. And as everyone gets more and more used to things, comfortable with the approach. And so this is an interesting review of 20 patients. Only one of their patients was a current smoker. I have it in blue over here. And then that'll come up on the next slide. 19 out of the 20 had tonsil tumors. And I showed you here with the blue that 50% of the patients were clinically T4. I was very surprised when I saw this. And what we'll see on the next slide is on the right side, pathologically, only one of the patients was T4. And so I think this is a really interesting finding to see. But what you'll see from this slide is the take home of what do they use for reconstruction of these patients with retropharyngeal carotid. 90% of them received a radial forearm free flap. Here's a schematic picture. You can see the distal forearm. They actually de-epithelialize a portion of that, and they have a portion for the nasopharynx and a portion for the soft palate. Interesting for their approach in that first they'll do transoral incisions with the robot, but they won't fully deepen all those incisions. And that makes sense. You got a retropharyngeal carotid, you're kind of coming blind because unfortunately we don't have surgical navigation for TORS in 2022, which many people are vigilantly working on. But so they do the partial incision and then go through the neck and protect the carotid and then finish the resection through that open pharyngotomy. They also advocated for not doing a prophylactic carotid ligation, which I think most of us will recognize as a standard treatment for traditional TORS. And that's because the carotid and that pharyngeal space is actually covered by tissue. And so what they experience is no postoperative bleeds or hematomas. And that just goes to show that carotid ligation is not necessary in this situation. They didn't have any carotid injury, no stroke, and importantly, 95% negative margins. So really cool paper. Thanks for sharing that with us. Next question, we will put up actually, let's not put up a question for this. I have one more after this. Apart from cases for retropharyngeal carotid, I want you all to think about, when does your team use a tissue reconstruction in the management of oropharynx cancer? For some institutions, it may be never, it may be with open salvage only or with TORS salvage. But specifically, let's flash this question up. I want to know that if you or your team are going to do a tissue reconstruction for a TORS case, what is your go-to? What's the workhorse at your institution? Obviously, all cases are different. We'll give it a few seconds here. Locked up. There we go. Or we're going to call it there. So about 2/3 of respondents here say that they'll use a forearm flap, and that really is what we would do at our institution. But again, every institution is different, and I'm going to show you some data here. This is from Gorf and the group at Gustave Roussy. This is a series of 50 patients who needed a free flap reconstruction in cases of TORS. And it was done for a variety of indications. Sometimes it was for a second primary within an irradiated field. Sometimes it was for a recurrence of the primary tumor. About 40% were in the tongue base and about 30% in the tonsil. These are long surgeries. The mean length of the surgery was almost 600 minutes. And they only used about 20% of the cases needed a forearm flap, and they really favored things like thigh flaps or scapulodorsal system flaps. They really emphasize that there's a learning curve to doing these cases of reconstruction. There's a learning curve for the flap inset. How do you access the pharynx? How do you get that watertight seal for the inset? And so they used the robot actually for a portion of the inset in about 3/4 of the cases. And importantly, they had a relatively good flap failure rate with only 8 failing. Notably, 1 out of 5 patients had a pneumonia, and it led to mortalities in 2 patients. This is, we talk about the swallow function that Kate highlighted. This is a really important consideration for our patients. And I think the last thing I want to emphasize is that all eligible patients started their post-operative radiation therapy within 6 weeks, which I really want to emphasize is a very important quality metric that we should be striving to achieve for all of our patients. Thank you.
Well, great. Thank you very much, Dr. Orozco. Last up, we have Dr. Van Abel.
All right. Can everyone see that okay? Good.
Yes.
All right. So I have the privilege of speaking with you all today, and I have 2 papers to share. The first question we'll answer is, for patients with HPV positive or pharyngeal squamous cell carcinoma treated at a high volume center, which of the following improve independently? And this is in comparison to a lower volume center. I am not seeing the polling results, so I don't know if there's a different way to see that. Oh, here we go. Perfect. All right. So all of the above, and that is definitely the answer I gave as well after reading this paper. So I thought this was a really nice paper. It came out in Cancer in 2020, looking at national treatment trends in HPV positive or pharyngeal squamous cell carcinoma. And the key authors were from Ontario. So this was a study that looked at the National Cancer Database. Basically, they looked from 2010 to 2014, so over a 5-year period, for any patients with HPV positive or pharynx cancer that underwent curative intent treatment. Interestingly, the NCDB added HPV status as of 2010, which is really wonderful because many of our large databases don't have that data. They base this on high-risk HPV 16, 18, not otherwise specified, or just listed as high-risk HPV. By the time they looked for people that specifically had squamous cell carcinoma, had at minimal, if they underwent surgical therapy, at minimum a partial pharyngectomy and regional lymph node analysis, and didn't have metastatic disease, they came up with about 13,000 patients that met their criteria. Within this, the vast majority were clinically T1 or T2 and had positive nodal disease. The median age was 58 years. The majority were male and white. 63% had private insurance and 84% had a low comorbidity score. So I think this is really interesting because we see different patient cohorts being published, and this is a pretty large national cohort, and it shows that the demographics are sticking largely with what we originally saw. Maybe the age is getting a little bit older. The vast majority of these patients are being treated with non-surgical therapy, so 66.7% non-surgical, with chemoradiation therapy being the most common at just about 60%. Single modality therapy was much less common, with just 13%, with radiation therapy alone and surgery alone, both less than 10%. Interestingly, you can see here that there was a trend towards increasing in non-surgical therapy and decreasing in what they're terming trimodal therapy or surgery followed by chemoradiation adjuvant therapy. This rate was 19% and it decreased over this time range. In addition, both radiation therapy alone and surgery followed by radiation therapy alone both increased during this time period. I thought this was really a very interesting way to look at some of this data. So they defined 4 different quartiles for the volume of cancer therapy that was provided at each of the different hospitals, with Q1 being the highest volume, Q4 being the lowest volume. And when you look at these plots here, you can see that patients would travel a lot farther to go to a quartile 1 hospital. Interestingly, a quartile 1 hospital had a 16% rate of positive margins, while a quartile 4 had a 36% rate of positive margins. I will share in the second article that I think 16% is far too high, but still it shows a significant difference, more than a 50% reduction in positive margins. Patients were more likely to undergo non-surgical therapy if they went to a quartile 4 hospital, and there was no difference in the advanced stage tumors that were being treated here. They basically found that there were certain predictors of different therapy types. So for non-surgical therapy, as you'd expect, patients had increasing T stage, increasing end stage, and decreasing hospital volume. Patients undergoing surgical therapy were typically younger. They were a little sicker. They lived further from the hospital, often more female patients, which I thought was interesting. They were at a higher volume hospital and often treated in the Pacific region of the US. Those undergoing adjuvant chemoradiation therapy, so following their surgical therapy, were younger, went to hospitals with lower volume, had a higher end stage, had positive E&E or positive margins, although I'll highlight that 20% of the data that came from NCDB did not have data on E&E. So their conclusions here were that there were 3 treatment themes that would predict what treatment selection was chosen for each patient. The first was based on disease, so TNM staging as expected. The second is hospital characteristics, so the volume of the hospital, the geographic region in the US, and the distance from the hospital to the patient all influenced treatment choice. Patient characteristics, including comorbidities, race, sex, and age, all influence treatment selection as well. There's in the discussion, I thought that this reference was really interesting. David et al. Published again in Cancer in 2017, highlighted that treatment at a high volume center conferred about a 20% survival benefit, similar to what you can see in chemotherapy. The addition of chemotherapy was what they highlighted. And the authors of this paper concluded that this may be partly associated with the volume to margin relationship observed here in this paper. So I thought that was pretty interesting. If we have any questions there, otherwise I can go on to the next paper. I'll go ahead. So the second paper highlights a little bit about the margin status and training of our physicians and training of our surgeons. So the question is, what metrics do you think should be used to credential surgeons to perform transoral robotic surgery and transoral laser microsurgery in a clinical trial? This is a tough question because it should be a select all that you like.
While we're polling this, quick question, is there a robotics committee in any of your institutions where they actually track numbers and they have requirements, or is it department based?
We have an institutional robotics committee that looks at volume of cases and what's being used, things like that. We also look at case numbers.
Is there a cutoff?
No, I think that we departmentally have looked at 20 cases, as many institutions and many publications have suggested. So for example, we've had some surgeons who are interested in doing some robotic surgery, looking at sleep surgery, or potentially, something other than head and neck oncology. You didn't come from a head and neck fellowship. And we looked at 20 cases and having proctoring and having our more senior surgeons be present for their cases until they got to that 20 case mark. We also do the simulation based training as well. Okay, so it looks like we have the poll back. 50% of folks suggested that the number of cases per year completed by the surgeon should be used. The runner-up was fellowship training that includes TORS or TLM. And then distant third, it looks like, was positive margin rate. And so let's see what these folks thought. This was a paper published in Oral Oncology in 2020. It had a wide variety of authors, including one of our esteemed colleagues on this panel. And this was a novel surgeon credentialing and quality assurance process using transoral surgery for oropharyngeal cancer and ECOG 3311. So basically, to recap, this study was a phase 2 randomized controlled trial of transoral surgery, followed by low dose or standard dose risk-adjusted postoperative therapy for stage 3 to 4A AJCC 7th edition cancer. They ultimately they enrolled a little bit more than this, but they ultimately operated on 495 patients. So it's a pretty big cohort of patients. They instituted 2 procedures in their study. First was surgeon credentialing, and I have 2 L's there. I think there should be 1. I went back and forth several times. The 3 criteria for surgeon credentialing or active hospital credentialing, that they had over 20 or more cases of transoral surgery for oropharyngeal carcinoma. They did not allow you to have a benign pathology, but they did allow some to be salivary malignancies. And then they took 10 paired operative and pathology reports from within the prior 24 months, and they reviewed those by a panel of 10 head and neck cancer surgeons that were deemed experts in the field. After being credentialed, surgeons underwent ongoing quality assurance, and if there were any concerns, that surgeon was placed on hold. They did have the opportunity to re-credential, and a few surgeons did do that. Reasons for concern would be if they had a greater than 10% positive margin rate, if their oropharyngeal bleed rate escalated above this 21% stopping rule, and if they accrued less than 1 patient in 12 months. So this was what they found. They had 120 surgeons that applied for participation in the study. 108 completed the questionnaire. 47 were approved after initial submission. 40 had to submit some additional information. So a total of 87 surgeons were ultimately approved. The non-approval criteria were largely because people didn't submit adequate material or they didn't complete their questionnaires. Of those surgeons approved, surgeons were placed on hold. 4 surgeons were placed on hold because they didn't accrue anybody in over 18 months. All 4 of those surgeons were re-credentialed. 2 surgeons should have been placed on hold because they had greater than 10% positive margin rate, but that wasn't identified till a little bit later on in the study. They didn't have a great way to be real time with that. And then surgeon with no patient safety events or enrollment lapses were a total of 81 of the 87. They had a composite endpoint of positive margin rate and their grade 3 or 4 bleed rate, which were based on the CTCAE adverse event criteria. They had a 3.8% positive margin rate and a 5.9% grade 3 or 4 bleed rate, which I'll remind us in that last paper I showed for quartile 1 hospitals was 16%. They did have 1 death, a grade 5 bleed, and this was prior to them requiring vessel ligation, but the percentage there comes to 0.2%. They also looked at neck dissection nodal yield, like we talked about before. They didn't look at the ratio, but specifically at the yield. And they used a cutoff for minor surgical quality deviations of 15 to 20. So anything over 20 was considered a good neck operation. 15 to 20 nodes was considered a minor surgical quality deviation, and less than 15 nodes was considered a major surgical quality deviation. And the vast majority, almost 90% of their surgeons had lymph node dissections with 20 or more nodes in them. So the conclusions from this study, this was a great proof of concept that a comprehensive credentialing process can support a multi-center transoral head and neck surgery oncology trial with a very low incidence of positive margins and a low rate of grade 3 or 4 oropharyngeal bleeding. So I thought that this was nice, especially as we're all thinking about how do we put together big trials where we can include people from across the country, different patient demographics, et cetera. You know, we need to have some sort of criteria to be able to identify who should be operating on the patients enrolled in the study. And then I added a couple slides here because I did find that paper defining the prevalence and prognostic value of PNI and LVI and HPV or pharynx cancer. So here's that reference. And then there was one risk stratification scale where they included PNI and LVI. They ended up dropping PNI. So there's some articles there. It's good to have a phone a friend radiation oncologist who like knows every article under the sun. So
It's live updates. Well, thank you very much. I apologize. It looks like we're run 11 minutes over. But wanted to thank everyone for joining. We had a great turnout. There was a question, they don't want to be named on this, but should we come up with a certain credentialing process that can explain some of the morbidity reported in the ORATOR 2 trial compared to the ECOG 3311? Yes, a lot of us are thinking about this, and that's a whole different discussion. But thank you all very much. Thank you very much to the panelists, Dr. Thomas, for moderating this talk. And this was almost 125 people showed up. Looking forward to seeing you all in HNS. And there's Dr. Holsinger in, wow, that also sunny San Francisco. I mean, sunny Palo Alto.
Thank you all for joining. This was a marvelous panel and good discussion. So thank you all. And Kartik, you are amazing. I'm really inspired by you. I told you that before. Thank you, thank you, thank you.
Giovanna and Karthik, thank you both for a really lively and interactive session. Great papers. I have missed several of these, so really grateful for the pandemic papers, and thanks for everyone's incredible engagement today. So virtual and real applause.
Thank you. See you all.
See you in Dallas.
See you all.
All right, bye-bye.